Good morning, everyone. This is Cassie Sauer at the Hospital Association, and we are in the process of giving you recording privileges and letting folks into the meeting, and it takes us a minute or two to do so. So we'll be back with you shortly. Thank you so much for joining us.
Recording in progress.
For folks who've just come in, this is Cassie Sauer. I'm the CEO of the Hospital Association, and we're waiting just a minute or two while we give everyone recording privileges and admit everybody into the meeting. Actually, I'll make an offer while we're waiting. We've had questions about, can people come watch people get vaccinated or get footage of people being vaccinated? I've got 2 kids in the 12 to 15 range who are now eligible for boosters. We currently have an appointment at the FEMA site on Sunday, the Auburn FEMA site. I may be looking around for pop-up. I live in South Seattle, pop-ups that are closer to me, but that's probably where we'll head. And if anybody wants to get video of or photos of kids getting their shots, their booster shots, my kids would be willing to do it. You could send me a chat.
And we're currently good on my end.
Okay, great. There's 3 people in the waiting room, Ryan.
Mm-hmm. Yep, I see them. They are currently in the process of joining.
Great. Ashley, everybody good on your side?
Yep, good on my end.
Okay, great. Well, good morning, everyone. Thank you so much for joining us. I am sorry to say this is probably going to be a fairly somber briefing today. I liked it better when we told you that we were planning to cancel our briefings for the next month or so because we didn't have much to say. We actually have a lot to say today. I'm joined today by June Alteris, who is a nurse, and she's the Chief Quality and Safety Officer at MultiCare Health System, which has got a broad range of excellent hospitals throughout Pierce County and in Spokane and across the state. So we're thrilled to have June here. We have Sherelle Montani, who is the leader of Peace Health St. John in Longview, down in Southwest Washington. We have Dr. John Lynch, who is the Medical Director for Infection Control at University of Washington and Harborview. And from Evergreen Health in Kirkland, and just to remind you all, Evergreen Health is the discoverer of COVID in America. Dr. Frank Rito specifically is the discoverer of COVID in America, the Medical Director for Infection Control, and Dr. Ettore Palazzo, who is the Chief Medical Officer. So thank you all so much for joining us. So I'll start with some opening comments. Today we have, or yesterday, we had 1,387 patients hospitalized with COVID across our state. 126 of those were on ventilators, and there's about another 100. There's always for those of you who look at the dashboard, there's always a COVID suspected. There's about another 100 who are in the hospital awaiting test results, but probably have COVID. I think most of those COVID suspecteds actually do convert into COVID confirmed. A month ago, so this is a big change. A month ago, the 7-day average for patients hospitalized with COVID was 664. And the most recent 7-day average was 1,248. So when you're looking at those week-long averages, this is an 88% increase. Additional 583 hospitalizations in a really short period of time. And fortunately, we still are below the Delta peak for hospitalizations, but the rate of acceleration is very, very alarming. Some good news, and I think we'll ask our excellent infectious disease physicians to talk more about this, is that we are seeing evidence that there are patients that are newly sick with COVID that are not as sick as they were in the Delta wave, that people can come to the ER and some can be treated and sent home, and some are admitted to the hospital, but for a short time, then they don't need ICU care. Some of that is still to be seen, I will say, because we are like at the beginning of the wave, so we don't know what's really going to happen. It's also important to know that Delta is still here. Omicron has not completely knocked out Delta, so we've still got some Delta folks. And this is confusing, I think, and we'll ask Dr. Lynch and Dr. Rito to talk about this more. I think it can be hard to figure out how to treat the patient because you don't know which variant they've got, and so that's tricky. But we do still have some people getting super sick. So that's actually the good news, that it doesn't seem to be causing a severe illness. And the bad news is that hospitals are really, really full and staffing is incredibly tight. And one thing that is new for us is we have a lot of hospital staff who are sick, who have tested positive. Many, got it from a holiday gathering or, from kids out in the community. So we've got a lot of folks who are calling out sick, and that is really, really worrisome. So we do not at this moment have room to care for even a small number of new COVID patients. And we expect these numbers to keep climbing. The case growth that we see in the community is staggering, not hospitalizations, but the number of cases. So just to remind folks, it was about 2,000 on December 1st, and it's about 8,000 on December 31st of daily new cases. And we also know that number is very much undercounted because it's hard to get a test for one reason thing, and people also are doing home tests and finding positives, and so those are not necessarily included in the number. Unlike airlines who can cancel planes when staff call out sick, or other industries that can scale back their operations, we cannot close. We have to take everyone who walks through the door. There is a federal law called the Emergency Medical Care Treatment and Active Labor Act, or EMTALA, that requires hospitals to screen and stabilize everyone who comes to their ER. So the overrun that hospitals are feeling right now is dramatic. The patients who are difficult to discharge, we've talked to you about this before, is getting worse. A lot of nursing homes have outbreaks of COVID, and so they are unable to accept new patients. We are desperate for help on difficult to discharge, truly desperate. And you'll hear about this. The number of patients who are in the hospital who have no medical need is remarkable. There's some things that we are looking for. We want right now, I think we've mentioned this before, I just want to explain it in a little more depth. In Washington State, there has been a new interpretation of law about who can consent to someone moving to a nursing home when the patient can't consent for themselves. And in Washington State, there was a new interpretation done by the state that says that a spouse or a child can't consent unless they have power of attorney. They have to get a guardianship appointed. These are the same people who can consent for care to be withdrawn. So as a spouse of someone who's in the hospital, you could consent or do not resuscitate. You could consent to the person ending care or not resuscitating the person. You could not consent to the person moving to a nursing home. This is ludicrous. It needs to be changed. We are desperate for help on that. We would like to see more COVID positive units in nursing homes. Those patients can move out, more strike teams given to nursing homes. They can staff up and be ready to accept patients. Those are just a few of the pieces of help that we're asking for. But the consequence of this is that patients who need care are not getting it. Many people in the last week or two have received the very bad news that the procedure that they've been waiting for has been canceled or delayed. And these are really serious services, and it's devastating for the patient to hear it. It is very difficult for them both physically and emotionally. It's terrible for the caregiving team who's having to deliver this news. So, imagine if you've got a patient that you've promised, you've had a cancer patient and you promised them that their colostomy reversal is going to happen this week, and you call them and say, it may be a few months. I mean, that is devastating news to have to deliver. Or a cancer patient to say, we can't remove your cancerous tumor. And so the hospital clinicians are absorbing the frustration, sadness, and fear of the patients that are receiving these calls. We see ER visits going way up. Some of it's weather, some of it people who were out in the cold and got, affected by the weather. Some of it's COVID, some of it's delayed care because people have not been getting the regular care that they need. And so they're getting sicker. And the crunch in the ERs is really alarming. So we come here today with several urgent requests for the public's health. The first is, if you think you have COVID symptoms and you don't feel great, but you feel kind of fundamentally okay, you can breathe and you feel kind of more or less like you have the flu, stay home. Do not come to the emergency room. We have way, way, way too many people come to the emergency room looking for testing. The emergency rooms are not testing sites. This is especially, there's been a huge jump in people 25 to 49-year-old coming to the emergency room looking for minor COVID care. And as I mentioned before, there's a federal law that requires us to screen and stabilize every patient who comes. And it is causing a huge backlog in our ERs. It's jeopardizing care for people with true emergencies, and it is totally burning out our staff. And the other piece about this is if you have COVID and you've got mild COVID, and you come to the ER, you could be infecting someone who's there who's having a stroke or having a heart attack or got in a car wreck. So you're jeopardizing them. Please do not do this. The second piece is wear a better mask. We invite you to take your cute floral or Hello Kitty or favorite sports team cloth mask and put it right in the garbage, or maybe hang it on your wall as decoration. At the most, what you could do with it is put it over a surgical mask as a second layer of protection. We really want people to be wearing surgical masks, KF94s, KN95s, or N95s. These are all great options, and especially the KF95 and the KF94 and the KN95s are pretty widely available for purchase. The third piece is, I think folks heard the governor say yesterday to avoid doing in-person things if you can, just for a few weeks, and we echo that. If you can do something without being in person with others, that's a smart thing to do right now. If you can stay home or take a walk outside with a friend, do that for your own protection. And then finally, perhaps most importantly, is if you're not vaccinated, get vaccinated. If you're not boosted, get boosted. It will protect you. You are exceptionally vulnerable without it, and you are likely to take up healthcare resources someone else needs. That person who's not getting their cancerous tumor removed, there's a direct line between not getting vaccinated, taking up a hospital bed, and having that person's care delayed. So really, for the health of the community, please do that. All right, with that, I think I will turn over to Dr. Lynch for your comments about what you're seeing throughout the UW system. Thank you.
Sure, thank you so much, Cassie, and thank you for that incredibly good summary. I think a lot of what I'm going to say is really going to reinforce what Cassie just talked about. As mentioned, my name is John Lynch. I'm an infectious diseases doctor. I lead our clinical response for COVID at UW Medicine. I'm based at Harvey Medical Center in Seattle, Washington, where I lead the infection prevention and employee health teams. I agree with Cassie, we're in an unprecedented time. We started responding to this pandemic in January of 2020. And throughout that, we've been able to respond to pretty much every twist and turn. But right now, we are closer to crisis situation than we ever have been. In just the last couple of weeks, looking at the days leading up to the Christmas holidays, when we were about 30 patients with COVID across the UW Medicine system, from that day, roughly 2 weeks ago till today, we've increased to 144 patients with COVID-19 in our facilities. As Cassie mentioned, this is a mix of acute care patients. We have a lot more acute care patients with COVID right now than we've had in the past proportionally, but we still have nearly 30 people in the ICU with COVID-19. And these numbers are growing every single day. When we look simply in King County, the number of hospitalizations in the last 7 days has increased 76% on top of an increase in the 7 days before that. And unfortunately, just recently, we're starting to see an increase in the number of deaths, with a 50% increase in the number of deaths in King County due to COVID-19. So while I agree with Cassie's point that Omicron does appear to be associated with less severe disease, right, with more of our patients not requiring hospitalization, a greater proportion in our acute care, so the regular part of the hospital, fewer people in the ICU, we still have a lot of people in the ICU, and we're still seeing people die from COVID-19 as a result. So these numbers are incredibly significant, and the pace with which we've dealt with them is greater than we've ever dealt with before. And just to be clear, within UW Medicine facilities, this is the largest number of COVID-19 inpatients we've had in the entire 2 years. And we're going to see this exact same trend in every single hospital in our state. If they haven't gotten there already, it's going to be there in days to weeks. This is impacting a huge number of our operations. You may have already seen that we've had to discontinue non-urgent surgeries across our entire system, which creates additional barriers for access to cares across all of our hospitals and across all types and modalities of care. For various reasons, the need for care in healthcare, in clinical situations and in hospitals, has really been at high demand after that first 2 years of the pandemic, with people really needing access for lots of different reasons, a lot of delays in care due to prior parts of the pandemic. And we were already dealing with an incredibly high capacity across our facilities. Most of our facilities were at or over 100% capacity before this surge. And then adding the additional need for and demand for patients with COVID has put us well over that 100% capacity that we're already at. That challenge of patient need, which we definitely want to deliver, is being incredibly impacted by lots of other parts of this. And as Cassie mentioned, our healthcare workforce is being hit just like the rest of the community. Within UW Medicine, we currently have over 600 health workers who are impacted by either infection and the need to isolate, or because they have someone who's infected at home and need to quarantine to try to keep the rest of our facilities safe and functional. This is obviously impacting our ability to deliver that demand, that care that's needed in places that are already 100% full and now have the additional need for caring for this huge surge in COVID patients, which I would also point out, we do not know when that peak is going to come. This is obviously impacting our ability to deliver care in emergency departments, in clinics, in surgery, in our acute care and ICUs. Really importantly, though, that issue around healthcare worker impact is impacting the ability for folks in the EMS community to bring patients into our facility. It's impacting the ability for people to handle post-death situations in funeral homes and similar. And our hospitals are getting fuller and fuller and fuller as a result. And this is a significant problem for our community, and it's really a public health threat. The other issues is, as Cassie mentioned, is that while we're bringing all these patients in, mostly through our emergency departments, we cannot get patients out. The healthcare worker COVID-19 impact in long-term care facilities, in rehabilitation facilities, in skilled nursing facilities is hitting them especially hard, making it very difficult for us to discharge patients. Across UW Medicine, we have approximately 200 people who do not need to be in the hospital right now, but we have no place to put them. So when you think about the number of patients coming through our front doors, needing care, the care that we want to deliver, we don't have space because we, one, have too many patients needing care, not enough healthcare workers, and the inability to move patients out to the next appropriate level of care, which is, again, all together is putting us into a situation that is unprecedented, that we've been able to manage for the last years, but is becoming increasingly unmanageable. Another big part of this is the testing access. UW Medicine has been doing a huge amount of testing throughout this pandemic, but with the transition from Delta to Omicron and the incredible number of Omicron cases coming in, their ability to do mass testing has been severely impacted despite working extraordinarily hard for the last 2 years. And again, the healthcare workforce impact on those laboratory workers is the same as we're seeing in hospitals, in EMS, and every other part of society. And so they're struggling with staffing to get this work done in a way that's more complicated than it ever has before. And that's leading to the barriers around access to testing for healthcare workers, healthcare worker families, the general community, and others. We also know that with the inability to actually provide testing means that we're underestimating the number of cases out there. So despite seeing an exponential increase in cases, particularly in the western part of Washington, and soon to be in eastern Washington, that is an underestimate and probably a gross underestimate of the number of cases that are going on out there. We hope that antigen testing, and really in favor of the governor's announcement for the state to be able to provide some of these, and here in my county, our King County leaders to provide these tests. But we have to remember, we haven't really operationalized those, and is yet another piece of the puzzle that we need to think about how to make work for our communities, our healthcare workforce, and patients there. Some little glimmer of good news, though. I can tell you that we're working very hard on making sure that vaccines are accessible, making sure that these boosters are accessible to everyone who can be boosted, including this new younger cohort, which we're really excited about. We are starting to offer monoclonal antibodies for both pre or post-exposure prophylaxis, as well as treatment, as well as the new oral medication, Paxlovid. But I also want to caution people that both the supplies of all of these are extremely constrained. So as much as we want to be able to provide them, the supply is still very limited, and we hope to be able to provide greater access in the near future. So I will stop there. I will just close with reinforcing what Cassie said. This is the time to try to increase your distancing, to decrease your risk by avoiding gatherings in indoor sites without masks, to please level up your mask, get vaccinated if you're not vaccinated, and get boosted if you're not already boosted. These are the things that need to happen in order to keep all of our parts of society moving forward. Thank you.
Thank you, Dr. Lynch. Dr. Rito, let's turn to you. Let's keep the infectious disease leadership going.
Thank you. I'm Dr. Francis Rito, Medical Director, Infection Control and Prevention at Evergreen Health. And We've been doing this almost 2 years now, and this pace reminds me really of where we were in February and early March 2020. I really would just like to reinforce what Dr. John Lynch said. I think he eloquently stated most of the problems. A couple of things I'd like to reinforce, and this gets more towards the treatment aspect of it. There are new monoclonal antibodies available for the treatment of Omicron. However, they are in short supply. And our capacity to distinguish between the previous variant, Delta, which was almost exclusively circulating in the United States as early as December 2021, and Omicron, which now has really overtaken Delta, is difficult without sequencing. There are a few small things that you might be able to do, but it's limited, and it really hampers our capacity to make rational decisions until Omicron really takes over. Molnupiravir and Paxlovid have both been approved by the FDA, however, are in short supply and not readily available. And I think that may be an additional problem. And how we distribute those treatments, both the monoclonal antibodies, sotrovimab, which works against monoclonals, the pre-exposure, as well as the antivirals in an equitable way to allow those at greatest need, those that are immunocompromised, for example, on transplant medications, profoundly immunosuppressed, those that do not have the capacity to make antibodies in response to vaccine. That is a real problem, and I think it's something we're going to be tackling in the next 2 to 4 weeks. I think we do expect supply of these agents to increase fairly significantly in the months ahead. However, in terms of what we have available right now for this massive surge, very, very limited supply, and is being prioritized to those at greatest need. I would reinforce a couple of messages. In addition, a lot of providers, or some providers, are sending patients to the emergency room with the expectation that they might be getting treatment with monoclonals or antivirals there. And that's an unrealistic expectation because the prioritization of these treatments takes into account the entire population, not just those that can make it to the emergency room. So I would just ask people not to send patients to the emergency room or urgent cares with the expectation that they will receive therapy with one of these monoclonal antibodies specifically directed against Omicron or the new antivirals. At least not now. I think one other point that I would just like to reinforce is the very dramatic effect this has had on healthcare workers. They've been doing this now 22 months. They've been through ups and downs, multiple different waves. This has a totally different feel to it, just in terms of the scope and the breadth of infection that's now occurring in not only the healthcare workers, but their families, which takes people out of work and makes it more difficult for those that remain. So that we're looking at all sorts of options to get people back into the workforce to provide care, quite honestly. As Cassie so eloquently stated, we do not have the option of closing down. We can't close the doors and say we're full, come back in a few days, try another time. So I think being cognizant of that impact as well, and perhaps being a little bit more tolerant, a little bit less frustrated when you can't get what you need in a timely way, would go a long way towards making everybody's life a little bit easier while we struggle through these difficult times ahead. I think I'll leave it there. I'm sure there'll be many questions and we can answer those specifically. Thank you.
Thank you so much, Dr. Rito. June, I think Dr. Rito was starting to talk about the staffing impacts, and I know that's something that you've been thinking a lot about.
Thank you, Cassie. We at Multicare are having the exact same experiences, and we would just support and validate all the asks that Cassie and John and Frank have made. To be a little bit more specific, I will tell you that our caregivers, and that's all of our caregivers, I'm not just talking about clinicians, our environmental services staff, our security staff, our nutrition services staff, our engineering facility staff, everyone are being highly impacted, and that impacts the whole team. And you may be numb to these asks and numb to hearing about this and why is this different than what we've heard about for the past 22 months. For us, I will tell you that we have managed within our system to avoid what is called crisis staffing. We had to turn to crisis staffing guidance on Monday. So we are following Department of Health and CDC guidance related to crisis staffing that has different implications for when our teams can return to work based on their symptoms, severity of symptoms, their testing, their illness, and their workplace. However, what you're hearing, I think, and I'll just be really clear about it, our teams have rallied to support our communities for the last 22 months, and they really are at an unprecedented level of working overtime. All of our teams are fatigued and tired. And this piece about difficult to discharge, just to make it a little bit more clear, if we were able to move the patients out of our hospitals that no longer require our acute level of care, we would be able to put the people into beds who do require that acute level of care that we are now holding in EDs. And so this ask around not coming to EDs if you have mild symptomatology and or for testing and or seeking monoclonal antibody treatment, we are actually attempting to deliver inpatient care in our emergency department spaces because we can't get those patients into our hospital beds because we can't get people out into the community who no longer require that level of care. To put a tiny bit of perspective on that, the predominance of our 11 hospitals are in Pierce County at multi-care. We have 3 hospitals, 2 hospitals in South King County and 1 in Central King County, and then Spokane County 2 and Thurston County 1. We have 25% of the COVID positive patients in the state within our Puget Sound regional hospitals, and we are not 25% of the state footprint. And that plus 18% of our census is taken up by patients that no longer need our level of care. And we have 26% of our beds right now being taken up by COVID positive patients. And so this is, while it sounds the same as the last 22 months, it's actually very different in the proportion and the predominance of stress we're seeing. And it's really, I have been wishing and praying and hoping for over the last year that our teams can get a breather. There is some seasonality typically in healthcare, and our teams have not had a breather for 22 months, and it's really showing up. And their fatigue is turning into increased illness and the staying home with their family and taking care of themselves with their illness. So it is different than it has been in the past.
Thank you, June. Sherelle, let's hear from you.
Good morning, everybody. My name is Sherelle Montani. I'm the Chief Administrative Officer for Peace Health St. John in Longview, and we serve Cowlitz County. So I'm going to give just a little bit of a different perspective, although we're impacted in the same way, but really important issues for community and rural healthcare, which is really an important aspect here in Washington State. For our hospital, when we were in the height of the surge here, we had 62 patients that were positive with COVID. Our census that we were able to get to, which was extremely beyond capacity, was 142. And we were able to do that because we had closed our surgical services and created another ICU for patients that were not COVID. So before COVID, our average daily census was probably 85 or 87, and that's the amount of the workforce we had to take care of our patients. Since the surge, we've continued to have a really high capacity, and for us, that's 120 to 125. Right now, 25 of those patients have COVID. But I think what's really important and really concerning about what we're anticipating and planning for is we just don't have a lot of room. If we're already sitting at 125, we just don't have a lot of give to get much higher for what may be coming. Of course, we're doing the planning because we need to be ready to take care of our community, but that's the concern. Just to echo a couple of items, so we've got those 25 COVID patient positives. We're really challenged with those patients who no longer require care in the hospital. And it's really not the best place for them to be. We want to get them to the care that they should have, and we need those available beds for others. But today, for example, we're really waiting for guardianship on approximately 10 individuals. We're waiting on placement for skilled nursing for 12. And, in the past couple of days, we've been at times where there's been no availability. We also have another 8 patients that really need a higher level of care, like memory care, or another place that can take care of them in a safe way. And then what I think is really interesting when you think about that, if we could have those patients out of the hospital, as previously stated, the 12 to 18 people waiting in our ED at any time for admission would be in their bed, comfortable, getting the right level of care. I think, too, what I want to talk about, it's not just a day or two delay when we're not able to get people discharged appropriately. We have a patient who's been here over 100 days. We have 5 patients that have been here over 50 days. And currently we've got about 20 patients who have been here 20 or more. So we really have a lot of people that need a different place to recover. We are getting ready, and I'll echo what everybody else had said. This does feel different. The workforce is fatigued, tired, distressed. It's really challenging to be making those decisions on a day-to-day basis regarding capacity, if we can continue with surgical services or not. And I know people like to use the word elective, but it's really not elective when you think about a healthcare need that a patient or their family has. So for us, what would really help from a community is really for people to get vaccinated if they haven't had it. And there's still a fair amount of people in our community that have not, to really emphasize the booster and to really get some help on discharging and being able to place those patients. We rely on higher level of care. So just to help everybody, when our partners have the capacity issues that they have and they're not allowed to discharge, then they're challenged to take people who are too sick for us to adequately care for. So anything we can do to get people in the right place would be really beneficial. And then testing for the community. A lot of community members really want to have access to those tests to test at home. And we're really challenged in our community to have that. I will say our community has pulled together. We appreciate our first responders, EMS, and all our community partners. I think everybody's done amazing work, but as we get ready for what's going to come, we're starting at a place of really being tired and fatigued. So anything the community can do will really help us. And those have been stated, but absolutely, please do not come to the emergency department for testing or things that could be handled with primary care or just by some rest and staying at home. Thank you, Cassie, for the opportunity.
Thank you so much, Sherelle. I just want to follow up on that guardianship issue again that Sherelle mentioned. We do, as I said before, we think that this interpretation of the guardianship law is just really nonsensical. However, we are going to be working on a legislative fix this session, and what it would do is allow that same, there's a structure in state law for surrogate decision makers to make decisions about things like consenting to surgery, consenting to treatment, withdrawing care, do not resuscitate. They're allowed to consent to all those things. We want to have those same folks be able to consent to transfers in nursing homes as they used to be able to do. This is a new interpretation of state law. And we've also put in a request that the state examine whether the governor could use his emergency powers to allow that to happen now, because there are hundreds of people waiting guardianships, many of whom have someone at their bedside who could help them move. And I will echo what Cheryl just said. My father was actually in the hospital over the holidays. He fell. He's got Parkinson's, and he's not in Washington State. And I was able to consent to his moves and discharges, and he needed to go someplace else. You know, the hospital had to come and check on his vital signs all night long, and he was right by the nursing station, and he didn't get up to walk as much. He didn't get to go outdoors. Like there's a lot to. I obviously think hospital care is amazing. It's not a place to be when you don't need hospital care. It's not good for the patient. And I cannot begin to describe the frustration I would have felt if I knew he needed to move and I was not able to help him do that. So let's finish with Dr. Palazzo. Tell us what you're seeing. Round us out here.
Thank you, Cassie. Good to be with all of you and my colleagues here. What I'm going to share is not unique to what has already been discussed. I think what I'd like to point out is, and first, let me say that Evergreen has been doing this a long time. We weren't the first to identify COVID in the country. That was our friends to the north of us at Providence, but it was the first community outbreak identification that took place in late February that took us on this journey. So it has been a long time. And I would say that despite those very, very early challenges for us and what seemed like, until we were able to get some help from our colleagues, a potential crisis standards of care situation early on, which thankfully now 22 months on, we have been able to stave that off through excellent efforts, I think, from the state, our Washington Medical Coordination Center. But I would have to say, we are closer than we ever have been. And this is different than the crisis or contingency staffing situation that we've heard before. For us, we see this as a very unique convergence of events. And the Omicron wave certainly has brought record-breaking cases here locally and of course, across the world. We are grateful that it is less severe. I think the data is in support of that. But statistically, you can't argue that when you look at the exponential number of cases, there will be more individuals that need acute care. And we're seeing that. I'd say in the last 3 weeks, we now have seen a 60% increase in COVID cases here at Evergreen. Right now, as of this morning, half of our ICU beds are are full with COVID patients, and many are very, very sick. So that is the reality right now. And that convergence of the wave, certainly the acuity of the patients that are non-COVID that need care right now, and whether that was related to deferred care before or other phenomenon, that continues on. And then add to that the staffing challenges that predated our own staff that have been challenged with thankfully more mild illness from COVID but can't work. And all that together is where we're at right now. We too have 50 plus patients in the hospital right now that don't need to be here, that don't need acute care services. So that's about 16 to 20% of our beds that if we could move those patients to a post-acute care setting, we could open up space for more patients. I think the other thing that I would say is vaccine is more important than ever right now, along with our other mitigation strategies. I hear a lot of individuals reach out to me and say, well, this new Omicron variant, number one, the vaccines aren't as effective, or it's just a mild disease. This is going to be a common cold. And right now in our hospital, 60% of our COVID patients are not vaccinated. And so it is, the data is in support of reducing severe disease with vaccination. Certainly if you haven't received your primary series, needing that. And then those who are eligible for booster, definitely we see the benefits and reduction of severe disease in potentially needing a hospital bed. So I would just simply say, we are here to help you. We are here to help the community. We are not done yet. COVID, of course, is not done, but we need your help. I think you've heard from our colleagues here on what we need as far as utilization of our urgent cares and emergency rooms, what care we can give right now, and what you might need to do with regard to testing, and if you have mild symptoms and feel okay, and being able to deal with that outside of coming to the emergency room if possible. We are in a situation now where we've moved to, instead of crisis staffing, as you heard from June, we're in contingency, so we're that next level down, but we're ready to move to crisis and may very well need to do that from a staffing standpoint to deal with the patients coming our way. So Cassie, with that, I'll yield my time, and we're standing by to certainly answer questions.
Thank you. This may count as the most depressing media briefing we've had throughout the entire pandemic. I would like to say, as I said at the beginning, I really like the ones better where we say we're not sure we're going to need to talk to you all again in a few weeks because not much is happening. Okay, so you can ask your questions out loud, or we'll take them in the chat. And Steve, I see your hand up. I'll go take a question from the chat, and then I'll go to you. So why are hospitalizations going up so much faster this time? Is this because Omicron is moving faster or is more infectious? Dr. Lynch, will you take that?
Sure. Yeah. So I think it's pretty clear now that Omicron moves much faster than Delta or prior variants. The time from exposure to infection is much faster, and the ability for Omicron variant to move from one person to another is much better. Why that's happening exactly, the biological mechanisms aren't fully explained, but it is very clear that it moves across to more people more quickly, and from the time from that exposure to disease onset is much faster. So Omicron's sort of inherent characteristics sort of explain how fast things are moving. But we also have to remember that each time we see a variant, our sort of non-pharmaceutical interventions, right? The status of our community, its openness, the level of vaccination, open indoor gatherings like bars, restaurants, and sports events are different at each time. And when Omicron hit us, we were at a and we continue to be at a fairly open part of our sort of pandemic journey. So we have a very fast, quickly transmitting variant. It infects lots of people. It definitely impacts people who are unvaccinated. It does appear to lead to more breakthroughs compared to Delta, and it's happening at a time when people are gathering. And so all those things together, I think would amply explain why we're seeing this explosion.
It's a math problem, right? You just have so many more, even if there are fewer people that need hospitalizations from Omicron, you have so many more people that are infected that even a small percentage of a big number is a big number. And so it's just the sheer number of cases. It's staggering. Another question, are the majority of people hospitalized still unvaccinated, or are we seeing more breakthrough cases being hospitalized? Dr. Rito, will you take that one?
Sure. I think the majority still are unvaccinated, or more specifically vaccinated but not boosted. And we know that the Omicron variant, 2 doses of Moderna or Pfizer or Johnson & Johnson just do not offer significant protection against the Omicron variant. So it's important to go out and get your booster to up that level of protection. But in addition, and just to echo some comments that Dr. Lynch made, this virus Omicron has 32 new mutations in the spike protein. And I just want people to think of the spike protein as the key that opens the lock that gets inside your cell. And this mutation has been the refinement of a significant selection process. I liken it to a marathon race with 10 billion contestants, and this Omicron variant has surged to the front. It's the fastest, the fleetest. It's been reinforced. It gets into cells very quickly, very rapidly, very easily, multiplies rapidly, and then spreads quickly. And as you pointed out, Cassie, this is a numbers game. A small percentage of 1 million people is a huge number still. And some of those individuals end up in the hospital because they are infected with COVID and they have pneumonia or signs of infections. Others are admitted and incidentally found to have COVID. They come in because they've had a stroke, or they've had a car accident, or they fell off a ladder and they need medical care. And we now screen everybody that comes in, and they're incidentally found to have COVID with very few respiratory symptoms. This virus does have one other characteristic that's a little bit different. It doesn't seem to have as great a predilection for the lower respiratory tract. So we're not seeing as many pneumonias as we did with Delta and the earlier strains. But still, a small percent of a very large number is a huge number of people overwhelming our systems.
And I also want to say, as someone who's been on the hunt for boosters in the last 24 hours, trying to find boosters for my kids, they are available. I mean, I have made appointments at the FEMA site. I just got my scheduling invitation from UW. There's available there. There's some pop-up clinics. Like a lot of pharmacies are doing walk-ups. You can find a booster right now. It may take a little bit of hunting, but not a lot. So please, please
and
do.
It's not too late.
It's not too late, exactly.
I want to be very clear. People ask me this question. It is not too late to get vaccinated. It is not too late to get boosted. Still go for it, even if right now, if you just started that vaccine trip.
Right. And the boosters, I definitely just may be wrong. The boosters are effective pretty quickly.
Yeah, I mean, I think within days to weeks there, and I say weeks, no more than 2 weeks, but yeah, vaccination starts having impact within weeks, and boosters start having the same impact probably within days to weeks. And even for people who've had COVID, getting vaccinated and getting boosted is still really, really important.
I would just echo that the Delta, if you've been infected with Delta, you do not have much protection against Omicron. And so we're seeing people who have had Delta in the past, not gotten vaccinated, now coming in with reinfection or another infection, this time the Omicron variant. The good news is that maybe infection with Omicron will protect against Delta, but Delta may disappear and who knows what the next variant is. So vaccination is key, and it does appear that it provides protection against a variety of these different strains, but you need to get your booster to get your levels up.
Thank you. All right, I'm going to go back to the questions in the chat in a minute, but let's call on Steve McCarran.
Cassie, thanks. Two questions that I wanted to ask is one, I was struck by something that June said about how there are people that are going to be numb to these asks, which I know that this is something that we've heard off and on throughout the past 22 months. What is your message to those folks? And how do you think that you reach those folks that I've heard a number of you say that we are closer to a crisis situation than we have ever been throughout those 22 months? And my second question, I think, is somewhat similar to Debbie Cockrell's with the News Tribune, is in terms of crisis staffing standards versus contingency staffing, what does that mean for the patient in terms of care or what they can expect for their care? Thanks.
Let's start with how do you reach the numb public? Because that is definitely a worry. Anybody want to take that one?
I can take a crack at it. I remind people that we do not live in isolation. I have a granddaughter that I care about. Most people have children, grandchildren, parents, elderly parents, individuals who are susceptible. They have friends who have had transplants, who are undergoing chemotherapy. And I think we need to step outside of ourselves for just a moment to consider the broader impact of our actions, or more specifically, our inactions when it comes to taking appropriate precautions. And that includes being boosted or vaccinated at all, but it also includes not getting together and having large parties, gathering in groups, doing behaviors that at this point will only contribute to the spread of this virus. So I think I'm calling on some personal responsibility here and asking people to step up, if not for themselves, consider the broader implications. And everybody knows somebody that is at risk for severe complications. And I don't think we can take this casually.
I will say,
I can just add to that just quickly. I agree with Frank. Appealing to the heart and the head are both appropriate. Hitting people with numbers is important. We need to be transparent about what's going on and the impact of the Omicron surge. And so sharing that data is important, and how that's affecting healthcare, how it impacts individuals, how it impacts our society. But we also have to make sure that we're being compassionate. And I think calling people to recognize the impact in their personal lives to the loved ones they have, like Frank just listed, is really important. But that's not going to get through to everyone. And that's why we got to keep coming back to how do we deal with the challenge we have as a system, as a society. And so thinking about how do we keep healthcare functioning, thinking about it like a utility, right? How do we keep healthcare functional? We need to figure out ways to slow down the number of people come to the emergency departments. We got to figure out how to get people out to the right next level of care. We got to figure out ways to protect healthcare workers and healthcare workforce across the continuum of care. So messaging is really important. Calling on those folks who maybe have a little bit resistant to the message in different new ways is really important. We should be using all of the folks who are experts in communication, their recommendations around how to do this. But at the same time, we've got to continue to really lean in to how do we make this system function and figure out where those blockages are and address those urgently.
And Cassie, if I may, I would just add to that. I think we look to you as our colleagues and partners. I am not a communications expert. I'm an expert in healthcare operations, and we try to find a very fine balance. We don't want to panic the public. We are here to take good care of you. And yet we all know that we are saying this is different than before, and we are running out of the levers we have available to us to appropriately serve our communities. And so I think we would look to our partners to help us message appropriately that this is somewhat different than what you've heard about for the last 22 months, although the topics and the words sound very similar.
Thanks, John. I will say another thing that's worth noting is that people who have been numb and dismissive of COVID, when they wind up in the hospital and they're sick, or their family members in the hospital and sick, they are not numb and dismissive. They are desperate for care and begging for any treatment that can help them. And as Dr. Lynch noted, the deaths are still happening, and they're just tragic and shocking at this point. To lose someone to COVID right now is just an absolutely unnecessary tragedy, and will have huge implications for their families for decades. So that it's a tragic way to shake people out of their numbness, but it is definitely happening. Let's see, June, a couple of questions to you about what is the difference between contingency staffing and crisis staffing, and what does that mean for patients? And also, is that at all multi-care hospitals or just the West Side hospitals?
So right now it's our West Side hospitals. We are seeing early indicators that things may be increasing as far as the demand within Spokane. Early indicators of we have a drive-through testing site at one of our hospitals in the last 2 days. The lines for those have been longer than when they first stood those up. However, this is a distinction related to guidelines for return to work. And so we've moved to the CDC and Department of Health guidelines related to return to work in the crisis staffing so that we can continue to deliver the standard of care we expect our patients to receive. And so I want to make that distinction. It is a return to work guideline within Department of Health and CDC related to crisis staffing. It's not crisis staffing standards. I know it's words, but that's the distinction, so that we can appropriately bring back employees a bit sooner so we can continue to deliver the standard of care we expect for all of our patients.
Joey, you've got your hand up.
Yeah, thank you. The issue with patients not being able to be discharged seems like external factor that's going to drastically impact the next few weeks. Yesterday, the governor said that they've, trying to get some stuff through the legislature, whether that's funding or changing, tweaking the regulations. But, what can be done in the next 3 to 4 weeks is, we're getting ready for as the modeling suggests, 40,000 cases a day by the end of the month. What can be done in the meantime to make sure this isn't a gigantic issue going into next month?
Yeah, I think strike team assistance to the nursing homes that need it, that have been impacted by staffing, folks who are out on and their staff. As I mentioned, we've asked for the state to consider whether the governor has the power to waive the rule that says that you have to go through this extensive, laborious, ridiculous guardianship process in order to consent to nursing home transfer. Those are probably my top two. We may be in a place where we're asking for field hospital kind of services for folks who don't need long-term care. Anybody else want to chime in here, including Zosha Stanley from the WISHA staff about short-term help?
Cassie, the other thing that we have requested through WISHA, just as a reminder, is a request to either change the guidelines related to SNFs and when they can or cannot receive patients from us, or to open more COVID positive SNF beds so that we can move people out, because many of our SNFs are closed to admissions based on those guidelines and the limit of COVID positive. That's been a big ask through WISHA to the state for assistance.
Cassie, I would echo that. In the past 12, 18 months, there was a period of time when placement in skilled nursing facilities was very limited and restricted just because a patient had COVID or was still positive on testing. And at that point, I think the state did step in and provide additional funding to a select number of nursing homes that would accept these individuals who were either still positive by test or had recent COVID infections. So that's another avenue I think that could be reactivated and explored.
Thank you. Okay, some questions for Sherelle. Has PCell St. John had to divert staff from other departments to help in the ED or ICU?
Yeah, so let me talk about that for a minute, because it's always a really fluid situation of what our capacity is and how many folks are waiting to get into a bed. So we have what we call a daily huddle, where we look at our capacity throughout the hospital and then take a look at what's happening in other departments. And then when appropriate, people with the right skill set, we do move them to other departments to help. It could be an RN who has that strength and ability and that skill set, or it could be somebody we call helping hands to go and help with patient care. So that is something that happens, it's planned. We also are getting ready to stand up our staffing pool again, so that we can support those areas that are especially busy. Thank you.
A second question for you is, I think the answer to this is yes for everybody. Has there been an increase in patients testing positive for COVID who were initially admitted for other reasons? I think all hospitals are seeing that. You're seeing that as well, Sherelle?
Yeah, and I don't have specific numbers, but I think most of the folks that are here came in with COVID-related illnesses, but absolutely we are seeing a percentage of folks who are really here for something else. And then in our testing, it gets revealed that they're also COVID positive. So yes, both.
Okay.
Cassie, can I just follow up on Sherelle's comment on the first part? Is that what Sherelle's team is doing is what every hospital in the state is either doing or planning for. Every single hospital, particularly in Western Washington, where the first surge is hit, but will impact Eastern Washington in days to weeks, as I mentioned. And everybody is looking at where staff could potentially be moved because of the level of challenge we're seeing right now. I see June nodding and so forth. This is not unique to Sherelle's facility. It's just she's the one describing it right now. But I just be clear, it's happening everywhere.
Thanks, Dr. Lynch. Okay, this is a question. I think I'm going to send this to Dr. Lynch and Dr. Rito. We've heard many of you say it'll be important to avoid large, particularly indoor gatherings in the coming weeks. What are your thoughts on indoor dining, gym, movie theaters, etc.? But how are you all handling in your own lives? Would you go to those? What are you doing?
Well, we do not do that for a lot of the obvious reasons. Closed indoor spaces with a highly infectious variant, unmasked, it's just a recipe asking for infection. So I think you need to identify your pod, if that's a very closely held group of family members, and stick with that. This isn't going to go on forever, but it is going to go on for the next 4 to 6 weeks, I think, until we see this Omicron variant surge begin to attenuate. And their patterns, the South African peak, they're now on the downslope. And so this goes through fairly quickly. But again, every country is different and we have not reached our maximum point yet. So this is the time to stop doing those sorts of things. And again, you might do very well with Omicron variant infection, have mild symptoms, mild upper respiratory symptoms, but you could transmit that virus in the 1 to 2 days before you become symptomatic to somebody who is extremely vulnerable and at risk for much more significant morbidity and end up in the hospital or even on a ventilator. So be cognizant of what you're doing and remember that it's not just about you. It's about all the people around you that you might come in contact with.
Like Frank, I'm an infectious disease doctor. I haven't been in a restaurant since January of 2020. I haven't been in any bars, and the only people I hang out with are a very small group of pod folks. So I've been the same folks throughout. I will say that I do go to a climbing gym. I just want to be transparent, but I wear an N95 when I'm there, and there's very few people in the spaces that I'm in. And I know the air handling in each facility I go into quite specifically because I ask about it. And so if you don't know the air handling, filtration for your facility, if you can't space out, if you can't wear a respirator in those places, indoor areas, I think the risk is still very significant. So that's my practice.
And that's probably true of everybody on this call. Okay, and now Steve has ended us with the $1 million question, which is based on the current steps your hospitals have already taken to try to address the massive wave of need. What comes next and what options comes next if this continues to worsen? The worst option that we are facing is that we will have to deny care to people who need care. And that is terrible. And that could lead to their disability or their death. That's just to be very stark about it. Anybody else want to comment on that?
Cassie, I might chime in here. So indeed, that final step would be a crisis standards of care situation where specific care potentially could not be provided to those that need it. We are doing and will continue to do everything in our power to not get there. And so you've heard from many of the members here on the surge planning that has been going on, and the teams continue to be creative. Labor pools, other areas of what may be deemed non-essential care. I mean, all care is essential, but there comes a point where we say we can postpone that or these particular types of visits so we can bring that staff into a new area to support, and we will continue to do that as far as we can. But that final step would be a crisis standards of care situation that we've heard other areas of the country have to employ, and we're so hopeful that won't be the situation here.
And again, we need the public's health in this. Get your vaccination, get your booster, stay home, wear a better mask, don't go to the ER for mild COVID symptoms. We need the state's help. We really, as I said before, we are desperate to move the difficult to discharge patients, the patients who don't have a medical need, out of the hospital. That would create a ton of space. That's like 15% of hospital beds in the state. People who need staffing, in many cases, as June described, or I think maybe Sherelle, can't remember who said this, that folks who need memory care, they can't be left alone in their rooms. They need a lot of staffing in a hospital setting. It's not a good use of hospital staff. So we need help to not get to this point. We do not want to get to this point of denying care to people who need it.
Cassie, how close are we to getting to that point? I don't know if anybody can chime in on that.
I don't know.
Closer than we've ever been, ever.
Yeah. I think there's a stepwise progression here, and we're moving from routine staffing to contingency staffing, and you're already seeing some facilities move to crisis staffing ratios in care. And I think we have to recognize that with each of those steps, where we start to have more difficulty providing care for patients, and care is limited, non-essential or absolutely elective surgical procedures are canceled, and as has been pointed out, some of those are not really elective or non-essential. They're cancer surgeries. They're surgeries that are important for ongoing well-being. Clinics are being closed, restricted because they don't have enough staff to run clinics. And staff, quite honestly, are tired and they're burning out, and some are leaving the healthcare field entirely. So these all contribute to this slide into more difficult times for us to provide care. And yet we're asking more of all of our staff, of our providers, and of the people that are here. I spoke with one of the environmental services engineering groups. They're very limited right now. And you can see that now we're coming down to essential environmental services rather than the optional ones.
I'd also like to just remind folks that crisis standards of care isn't a hospital decision. That is a public health decision. Our health officers, our Department of Health leaders make those decisions so that they apply everywhere at the same time. We, as healthcare facilities, do not ever want to be there. We provide them with information. We provide them with the status of care we're able to provide. And then those leaders make that decision around crisis standards of care. It's not something that each hospital decides upon on its own because it is an incredible transition from what we would argue is providing the standard of care, which we're doing now, through all these challenges, to doing something that's not the standard of care, where we move from the individual to the population. And again, we don't ever want to get there. We're doing everything in our power not to get there, but we recognize that our public health leaders may recognize the stress that the whole system is under, the whole continuum from pre-hospital to post-hospital care, and decide that that's where we need to go in order to maximize health of the population. And I'll just point out that I mentioned before this surge, all of our hospitals were incredibly full, and that's a result of the last 2 years of the pandemic. And this is only going to continue that problem. We're going to be dealing in healthcare with this challenge for months and months, if not years to come. And so, next year, even if everything goes great, we're still going to be dealing with the impact of the delayed care to our patients right now out into the future, which means that, this isn't something that's just going to go away for any of us. Hopefully this critical situation will be addressed and we'll be able to deal with it and get through it. But the ongoing challenge of the healthcare system is not going away. That is going to be a persistent challenge for all of us and our colleagues, the people doing this work, and our patients, the people who are depending upon us for months and months and months, if not years to come.
Cassie, I
would just echo one point, and that is that the hospitals in the state of Washington, the healthcare providers, are committed to not allowing a single institution to move in this direction. We have been accepting patients in transfer. Patients are moved around. Alternative mechanisms are put into place. Our goal is to provide health care for not only our community, but if necessary, to assist other hospitals, as others have assisted us during our initial difficult times. So that is a commitment, I think, that Washington State has made, that the hospitals have made to each other, the healthcare providers have made to each other to make that happen.
Cassie, I just wanted to say that closer than we've ever been. We are running out of the levers and tactics we can use to facilitate this demand. And so people's commitment to doing the things that we're asking in this call that Cassie listed at the beginning will help us avoid that. And so we're asking for this help because we're running out of the operational internal levers we typically do to meet our community's demand. So adhering, complying, committing to the asks that Cassie listed would be tremendously helpful in us avoiding that situation.
Thank you. I think we're through all the questions. Just really encourage to build on June's comments, really encourage everyone in Washington to think compassionately about their neighbors and making sure their neighbors don't get COVID, and that their neighbors who have an emergency can get that care. People who need, even who find out they get diagnosed with cancer, can get the care they need, to really consider the state of community and to hold every member of the community in your hearts, and to do all you can to make sure that they can get what they need from the healthcare system. We rely on it every day, and I think people will be shocked to find that they can't get what they need. Thank you so much for joining us. I think the DOH is doing a briefing right after this, so sounds like there'll be some really good information from them as well. And I appreciate your being here. Thank you.
Thank you very much.
Thank you.
Thank you.